Hello and welcome to day 2 at ESICON 2018. Well, this is the 48th annual conference of Endocrinology Society of India. In conversation with us, we have Dr. Joseph Verbalis all the way from Washington, D.C. Let us get straight from him. Good morning, sir. How are you doing today?
Good morning. I'm doing very well, and I'm pleased to be here. My name is Dr. Joseph Verbalis, and I'm Chief of the Division of Endocrinology and Metabolism at Georgetown University in Washington, D.C. I've been there for more than 20 years doing research, teaching, and taking care of patients with endocrine diseases, specifically of the pituitary gland.
So talking about the kind of work that you do, could we have some more insights for our audience?
So the pituitary gland is divided into two parts, the anterior pituitary and the posterior pituitary. The anterior pituitary makes hormones that control various glands through the body, the thyroid gland, the adrenal gland, the ovaries, the testicles. For that reason, it's often called the master gland because it controls many other glands. In contrast, the posterior pituitary, which I mostly study, is a separate kind of organ. It's actually a part of the brain, not the pituitary. And it makes two hormones, vasopressin and oxytocin. Vasopressin is essential for maintaining water in your body. When you're outside on a hot day, and I know in Bhubaneswar many days are hot, you're obviously sweating. When you're sweating, if you're not drinking enough, if you don't have this hormone, vasopressin, you keep on losing too much water through your kidney and you can quickly become dehydrated. So you make vasopressin from the posterior pituitary, secrete it into the blood. It acts on the kidney and tells your kidney to save water. That's why on a hot day when you're outside, not drinking when you eventually have to urinate, your urine is a small amount and it's very dark yellow, meaning it's concentrated because you're not losing water, and that's very protective. With diseases of the posterior pituitary, when you can't make enough vasopressin, then patients cannot stop urinating. My patients with diabetes insipidus urinate up to 20 liters a day, meaning that they're urinating every 2 to 3 hours, which is not a pleasant life to lead. So we diagnose the reason and then we treat them. We do have a very effective treatment. We can give an analog of the hormone vasopressin called desmopressin, and that very effectively shuts off their urination so they can lead a normal life. Without that, their life would not be very normal at all.
Also, sir, since you mentioned about diabetes
insipidus,
sure. So, what are the kind of challenges in the diagnosis that you are facing along, and also that you are having a presentation on same today? So, could you please have an overview for us?
So the first challenge, of course, is to differentiate diabetes insipidus from the major type of diabetes, the type which is very prevalent in India and throughout the world, which is diabetes mellitus. Diabetes mellitus means sweet urine. That's what mellitus means in Greek. And that is because people with diabetes mellitus excrete a lot of sugar in their urine, making their urine sweet. Diabetes insipidus, that doesn't happen. There is no increased sugar in the urine, and therefore it's called insipid because the urine tastes insipid. It doesn't taste sweet. Not that we taste it these days, though that has been done in the past. And so it's very different, and that's your first distinguishing step. Make sure the patient doesn't have diabetes mellitus, has diabetes insipidus. And then it's largely a matter of differentiating the different causes of diabetes insipidus, and they can range from tumors around the pituitary gland to diseases that infiltrate the pituitary gland called sarcoidosis or histiocytosis, or a idiopathic form, which we now know is from autoimmune destruction of the pituitary. So like any other disease, there are many, many different causes of that disease, but once it results in destruction of the posterior pituitary, those people, those patients have diabetes insipidus and need to be treated for that.
Sure. Also talking about the common treatments and how to manage the same.
The common treatments really are very few for diabetes insipidus. Unlike diabetes mellitus, where we have a wide range of drugs and insulin, of course, to treat diabetes mellitus. There really is only one treatment for true diabetes insipidus, and that is the drug which is the analog of vasopressin called desmopressin. That drug was created more than 40 years ago, and it is such a good drug, so effective, that we really don't need a lot of other drugs. So we have the drug that can treat it, and the challenge really is just knowing for an individual patient how much they need and how much they should have. So we what we do is what we titrate the dose. We start with a dose or two a day. We see how the patient responds. If they turn off their urine appropriately, if it's not too much so they retain too much water, and then we titrate the dose for the individual patient. So it's not one standard dose that every patient gets. Every patient gets a dose based on what their needs are according to our observation of how the dose is working.
Sure, so thank you so much. It has been very insightful. And lastly, one giveaway message to our fellow physicians and endocrinologists who are not here but watching you live. What would that one quick tip for them be?
For diabetes insipidus, just remember that not all polyuria or increased urination is always due to diabetes mellitus. Diabetes insipidus is much rarer than diabetes mellitus, but you don't want to miss the diagnosis, especially in children and young adults, where it can have profound effects in terms of retarding their growth and development. So think of it, even though it may not be always at the top of your mind, when things don't seem to fit for a diagnosis of diabetes mellitus.
Professor, now let's talk about ESICON 2018. Is this the first visit to City of Temples here at Bhubaneswar?
Yes, my first visit to Bhubaneswar. I've been to Kolkata before, but never to this region, so I hope to see more of it while I'm here.
Sure. So what are your plans for sightseeing? I hope you are aware the fact Temple City of India. So a lot of temples to visit around. Are you excited for the same?
So I have in my training program at Georgetown University, there are many of my fellows are of either Indian ancestry or Indian descent, and so yes, they've told me about this area, so I know about it secondhand from them, and I certainly will try to visit the temples.
Sure. I hope you have a great stay here at Bhubaneswar, and thank you so much, sir, for joining in with us here on ESI TV.
Oh, it's my pleasure to be here. One of the great things about science and medicine is the ability to exchange ideas, to talk about our patient experiences. So I hope the attendees here learn from me, but I will also learn from them about their needs, about their concerns with the patients they have to treat. It's mutually beneficial for all of us.
Well, on this note, we end this conversation with Dr. Verbalis right here on ESI TV. Stay tuned with us for more updates. Thank you.